The update was published in the circulation online in October, so last. The importance of this document is that it lies in the fact that population is aging. Coronary heart disease population has increased, and more than half of this population is more than 65 years of age, coupled with an increased risk of stroke and peripheral arterial disease. Older patients tend to have more extensive coronary atherosclerosis, and coronary heart disease is still the leading cause of cardiovascular death in older adults. Apart from this, there are the related complications such as heart failure and arrhythmias, and these lead to significant morbidity with loss of independence and impaired quality of life, which are very important in the older population. There are an increasing number of randomized controlled trials addressing secondary prevention of atherosclerotic cardiovascular disease, and these are including an increasing number of older adults, but still few over 80-year-olds, much less than the actual representation in the population. This leads to the fact that a large proportion of elderly patients are not receiving evidence-based therapies in clinical practice. What are the goals of secondary prevention? In older adults, we aim to delay the progression of disease and major clinical events such as myocardial infarction, strokes, critical limb ischemia, thereby increasing longevity, improving quality of life, and maintaining independence, politically decreasing yearly healthcare costs. All this needs to be done whilst taking into consideration the increased risks in this population, increased iatrogenic risks, comorbidities, polypharmacy, socioeconomic stresses, and cognitive limitations. A problem in the older population is an element of diagnostic uncertainty. Acute coronary syndromes present differently. Chest pain is less frequent, heart failure becomes more frequent. The diminished activity levels in this population lead to lack of earlier symptoms. There is rarely exertional angina because they are frequently immobile patients or relatively immobile patients, so they tend to present at a more advanced stage. Exertional dyspnea, sometimes considered to be an angina equivalent, may be attributed to deconditioning, pulmonary disease, and heart failure in these patients, again leading to delayed diagnosis of acute coronary syndromes. And it is, of course, sometimes difficult to obtain a reliable history, especially in the setting of cognitive impairment and dementia. There is an increased risk of cardiogenic shock. It is 2 to 4 times more common in the older population. The increased heart failure rate, coupled with this increased shock, leads to a decreased prognosis, increased mortality, and decreased survival after first myocardial infarction, from 15 years in patients 55 to 64 years of age, down to 3 years in patients more than 75 years old. There is also increased risk following incident coronary events, hemorrhagic complications, stroke, reinfarction, or fatal coronary heart disease events, heart failure, and readmission rates are all much higher in the old. The 2011 secondary prevention updates had highlighted the first-line medications. These are all class 1 pharmacotherapies. I'm sure you're all familiar with them. Beta blockers indicated post-myocardial infarction. In the elderly, all these medications have increased risk. So with respect to beta blockers, you have greater chronotropic incompetence, so inability of the heart to increase its rate with exercise, leading in the elderly to exercise intolerance. ACE inhibitors or angiotensin receptor blockers are indicated in all coronary heart disease patients with a left ventricular ejection fraction of less than 40%, leading to increased falls and syncope in the elderly population. Antiplatelets and clopidogrel indicated in coronary heart disease patients and after stents, bare metal stents or drug-eluting stents. These are linked with an increased bleeding risk, especially in the setting of arteriovenous malformations or in the setting of associated warfarin use. Statins to lower LDL in patients up to the early 80s, increased myalgia and confusion in the older population. So these are all in consideration. The guidelines state that despite the class 1 indication for all these pharmacological therapies, they are still underused in the elderly, possibly explained by this increased risk associated with them. However, this underuse of class 1 indicated treatment extends to non-pharmacological therapies. Here it is worrying because, for example, cardiac rehabilitation, we know, has significant benefits even in the elderly population, yet it is still underused. In a cohort of myocardial infarct survivors aged over 65 years of age, statins were prescribed on discharge in 61%, beta blockers in 80%, and ACE inhibitors in 58%. All three, however, were only prescribed in 35%. Even after adjustment for contraindications, chronic aspirin use among older individuals is lower. The guidelines go into detail about all of these topics. I'll just be highlighting the important, more relevant updates. We'll start with cerebrovascular disease and stroke in the older population. 87% are ischemic and usually similar to heart disease due to disruption of atherosclerotic plaque. 8% one-month case fatality rate is associated with strokes, with a much higher residual disability rate, as shown in the Framingham study. Control of hypertension and hyperlipidemia remain very important, with strong and continuous reduction in new and recurrent stroke risk associated with these. Smoking cessation is also very important. Within 5 years of smoking cessation, the risk of stroke declines to that of lifetime non-smokers, which is quite encouraging. We'll move on to peripheral artery disease. It's common. There's a high proportion of asymptomatic peripheral arterial disease in the older population, similar to the high proportion of asymptomatic heart disease in these patients. Only 5 to 19% have classic claudication symptoms. As we said, it is very common in 60% of over 85-year-olds, according to the Rotterdam study. Potent risk factors remain smoking and diabetes. Effective treatments include supervised walking programs, smoking cessation, aggressive treatment of hypertension and hyperlipidemia, which we said are the important risk factors, and antiplatelet treatment. The guidelines highlight the importance of ankle brachial pressure index. It is a very quick, non-invasive bedside test that can be used in most places. You just need the equipment, which is very important. And they state that those with claudication or atypical leg symptoms and all those with known coronary heart disease or previous stroke should undergo ankle brachial pressure index testing. So we should be screening a lot of our patients. We'll move on to obesity. It increases overall mortality. 2/3 of the elderly are overweight or obese. Could be due to a metabolic rate declining. Changing lifelong dietary habits becomes difficult, especially in the older patients. There's a drop in physical activity. Hypoglycemic drugs, steroids, and antidepressants are all much more commonly used. There's an increased risk. Hypertension, hyperlipidemia, diabetes, and obesity is a significant independent risk factor for non-fatal atherosclerotic cardiac outcomes. The benefits of weight reduction include better blood pressure control and glucose control. There is inconsistent evidence on its effects on hyperlipidemia. There's a lack of evidence in the older population, at least, on weight reduction as a decreasing factor for atherosclerotic risk factors or events. However, what is definitely shown, there's evidence-based, as an evidence-based modality, it improves physical function and quality of life. Again, very important in the older population. Diet has been shown to be synergistic with exercise. And in the older population especially, we are strongly advised to include strength training, so not just aerobic training, but also strength training to help retain skeletal muscle and function, which will help keep an element of independence for the patient. Even moderate weight loss, 3 to 5%, so 3 kilos and 100 kilogram gentleman, are associated with clinically significant benefits. Hypertension, very common, 70% of adults over 75 years of age, possibly due to increased arterial stiffness, high salt diets, and sedentary lifestyle, accumulation of arterial calcium, renal disease, and the more frequent use of medications such as NSAIDs. Systolic blood pressure rises progressively while the diastolic blood pressure plateaus in middle age. So you get a widened pulse pressure with age. What is important is that systolic hypertension is present in 90% of hypertensive patients, but we should try and aim to decrease that, not drop the diastolic blood pressure. In fact, it's the fourth point, to prevent excessive reduction in coronary blood flow. In fact, some studies have shown higher coronary heart disease rates when the diastolic blood pressure is reduced to less than 70 to 75 millimeters of mercury. Hypertension management in the older population is associated with an increased risk of side effects to the medication and compliance issues due to cognitive decline. The goals have become less stringent. The target blood pressure is under 140 on 90 millimeters of mercury. In older patients, this target is based on expert opinion. A non-pharmacological approach should be tried. Lipids, LDL, remain strongly associated with coronary heart disease events in older adults, and statins have been shown to reduce death and recurrent cardiac events in older patients. The benefits: decreased mortality, non-fatal MI decreases, the need for revascularization and stroke also decrease. Significantly improved treadmill walking time before the onset of claudication. Some studies had shown possibly a reduction in risk and progression of dementia. Dyspepsia remains the most commonly reported side effect of statins. There's a higher incidence of abnormal liver function tests with high-dose statins in the older populations. Myalgias become more common as well. And the problem with myalgias is that in older patients, these can be attributed to aging or arthritis, so there's delayed diagnosis of these. They have been shown to possibly, there were some studies that showed a worsening in cognitive function and memory loss in the older population. So some studies have shown reduction in risk and progression of dementia. Others show increased cognitive function decline and memory loss. This has prompted a new advisory label on statins. The side effects of statins increase in this population. So the older population, especially females, small stature patients, concomitant fibrates and drugs using the cytochrome P450 pathway, use of statins during surgery, decreased hepatic and renal function, fatty liver disease, hypothyroidism, diabetes, and of course heavy use. You can use this to decide whether to give statins or not. Basically, patients with severely compromised life expectancy or quality of life may not be suitable candidates. It's important to take into consideration the patient's opinion. The patient may place more emphasis on the statin-associated reduced stroke risk and the prevention of worsening of claudication symptoms, despite the negligible effect on longevity. They're basically weighing quality versus quantity. Keeping in mind that randomized control trial data has indicated a 1 to 3 year time lag before the benefits of statins are demonstrable. The goal, again, has become less stringent. Targets have become less stringent. LDL of less than 2.6 as for younger patients with coronary heart disease, less than 1.8 in very high-risk older patients, and only with caution. A 30 to 40% relative decrease from baseline LDL may provide greater risk reduction. Statins remain first line. They are still underprescribed and underdosed despite the higher risk of recurrent events. Only 24% of patients over 65 years of age and 15% of patients over 80 are being treated with a statin after myocardial infarct. Nicotinic acid, in addition to statins, may further reduce LDL and triglycerides and raise HDL, but a study, the AIM-HIGH study, has shown negative results, so can be used but with caution. Ezetimibe has been shown to be safe in older patients, but hard data on its use, on the evidence of its use, is lacking. Fibrates may be effective in lowering triglycerides and raising HDL, but one meta-analysis did not show that fibrates lead to a risk reduction. And in the elderly, extreme caution must be used because of the increase. Alternatives to lowering LDL, cardiac rehabilitation over 75-year-olds has been shown to drop total cholesterol, LDL, and depression rates with increased HDL and quality of life. Again, quality of life variable population. We move on to diabetes. It's due to increased insulin resistance and impaired insulin secretion in the older patients. It is underdiagnosed in older patients because they present with non-classical findings, with non-classical symptoms. There is increased morbidity and mortality associated with diabetes. Routine screening is strongly recommended. particularly for older patients with atherosclerotic cardiovascular disease. Treatment must be specifically tailored to each individual, taking into consideration that you must manage hyperglycemia but reduce the risk of hypoglycemia, especially in the population. Trials have consistently observed either no effect or even increased mortality in older patients receiving intensive glycemic therapy. As a result, even in diabetes, targets have become less strict. The target HbA1c is less than 7% for adults less than 65 years of age. In older patients, it is 7 to 7.9, especially with chronic comorbidities, including atherosclerotic cardiovascular disease. In certain subgroup of patients, the frail, the increased risk of hypoglycemia, and the short life expectancy, even higher targets. Smoking remains the leading preventable cause of death worldwide. There is strong, consistent evidence of the increased rate of coronary and vascular events in patients with non-atherosclerotic cardiovascular disease, and the benefits are also shown in over 80-year-olds, so it's never too late to stop smoking. Smoking cessation drops the risk for mortality, non-fatal MI, sudden cardiac death, reduced risk of stroke, and it improves claudication symptoms. It is a Class 1A recommendation, smoking cessation. Despite this, success rates for smoking cessation remain modest. And we are still being advised to counsel the patients and use nicotine replacement therapies, which can improve the rates of smoking cessation by 2 to 3 times. Psychosocial issues, I know we don't usually like to go into a lot of detail, but they remain very important. Previously, type A behavior pattern was linked to an increased cardiovascular risk. Now we know that specifically the hostility component is linked to that, to increased risk. Depression is common and increases adverse events and mortality, and we should be routinely assessing our patients for depression, especially in the older population. Anxiety, very common in myocardial infarct patients, and it remains quite high. There's still quite a high rate 1 year on. But there are lower rates in older patients. Stress can trigger fatal cardiovascular events, and it carries an adverse prognostic value. This is interesting. The socioeconomic status and social support have been shown to be linked quite significantly to cardiac disease. The 5-year mortality rate is almost 2 times higher in lower income patients, independent of social isolation and disease severity. Emotional support before myocardial infarct was the most powerful and significant predictor of survival. So maybe we should be giving a bit more importance and screening our patients. Addressing psychosocial issues, the health benefits of reducing stress is not well established. There is a lack of data on the effect on clinical outcomes. Aerobic exercise, however, as a treatment for depression, has been shown to be quite significant, with a significant effect, and improvement is comparable to antidepressive treatment. So avoiding the side effects of the treatment and still getting the same benefit. Diet, we need to assess the dietary habits of older patients. The Mediterranean diet and flavonoids, fruit, vegetables, nuts, cocoa, tea, and wine remain quite important and have been actually proved to improve the outcomes. Interestingly, in the New England Journal of Medicine, they have published a report this week that a daily portion of nuts has been shown to reduce cardiovascular mortality by 29%, which is quite significant. Vitamin D deficiency is an independent risk factor for cardiovascular mortality in older adults. There are ongoing trials on the effects of vitamin D supplementation on atherosclerotic cardiovascular disease, so maybe we'll be getting more data over the next few months. Omega-3 fatty acids, there's still conflicting evidence. The benefits of exercise are numerous, as I'm sure you know. As we said, in the elderly, exercise should include aerobic, muscular strengthening, endurance, balance, and flexibility. Maybe not all our elderly patients will end up like that, but if we can aim towards something like that, it would be great. In older patients, we are advised to do a symptom-limited exercise test before initiating an exercise program, and we should be instructing our patients to report symptoms of chest pain and shortness of breath. High-intensity aerobic interval training has been shown to be more effective than continuous exercise at lower intensity. So basically short bursts of high-intensity exercise interspersed by longer periods of moderate exercise. Cardiac rehabilitation, very important. It has been shown that older patients benefit greatly from this, with a 21 to 34% lower mortality over the subsequent 5 years, independent of other risk factors. It decreases mortality as well by 19%. Despite this, the vast majority do not participate for a variety of reasons: lack of referral, patient-related factors, societal or economic barriers, current smoking, high BMI, diabetes, or cognitive dysfunction. Finally, coronary revascularization, CABG and PCI are being used more frequently in older adults. 2/3 of PCIs are performed in patients over 60 years of age and 11% in more than 80-year patients. There's an improved general well-being, functional status, and quality of life with decreased mortality. In older patients, the problems are that they have more calcified and tortuous vessels, with multi-vessel coronary disease becoming more prevalent, and peripheral vessels are more often abnormal. Peripheral artery disease is present in 25% of patients over 85 years of age. So, as a result, these procedures become more challenging and may lead to suboptimal results and complications. PCI, however, still carries a high success rate, and over 90% in older patients. There is reduced in-hospital mortality for patients over 80 years of age undergoing elective PCI after an acute coronary syndrome. The in-hospital mortality has decreased from 3.5 to 3% between 2001 to 2006 because of this. There is a reduction in major adverse cardiac events in invasive versus medical approach, with decreased duration of hospitalization, improved quality of life, angina severity and health status, and differences persisted at 4 years. Complications are more frequent: vascular and bleeding, particularly in very advanced age. There's still some uncertainty whether radial approach may reduce complications in this older population because of a lack of evidence. Therefore, an individualized decision whether to perform PCI in the older patient is being advised. CABG in older patients carries a higher risk of morbidity and mortality. There are increased post-op complications, but outcomes are improving. In-hospital mortality fell from 7 to 3 in octogenarians between 1990 to 2005, and post-operative complication rates also fell. How to choose which one to go for? Meta-analysis on octogenarians showed a similar outcome. Another meta-analysis, however, suggested a slight advantage for CABG patients with increasing age. Again, the decision must be individualized, taking into consideration improvement of symptoms, quality of life, and function, at least short term. In summary, the treatment advice is similar to the younger population, but with more caution. The aim should be improving function, quality of life, and independence in the older population, rather than longevity. Smoking cessation is the most likely modality to reduce mortality. Exercise training is the most likely to improve function, mood, blood pressure control. There is a move away from hard treatment targets, and the focus now is on identifying appropriate intensity of therapy for each particular patient. Ankle brachial pressure index testing, it's important and indicated in patients with known coronary heart disease and in previous stroke patients, especially with claudication or atypical leg symptoms. Cardiac rehabilitation, it has an unequivocal use, but it remains unfortunately underused. Consider PCI and CABG in older patients, but it is an individualized decision. I'll end with a quote from Edward Stanley in 1770. Those who think they have no time for exercise will sooner or later have to find time for it.